I'm sure we do. Yes.
Hi. So I'm Will Valiant here with Emad Madha, and we're here to talk to you about our involvement in a public health case competition where we came up with our pilot program, Inspire. So we are both from the Uniformed Services University of the Health Sciences, and USIS is the DoD's medical school. The majority of students there are medical students who are currently commissioned officers in either the Air Force, Navy, or Army. And there's also a handful of civilian graduate students who study the biological sciences, like myself. So at USIS, we have the Global Health Interest Group. Well, this is an interest group for any students to participate in who are just interested in global health and public health in general. And each year, the Global Health Interest Group puts forward teams for case competitions. And this year, we had 5 students participate in the DC team. And we decided to join this team because we wanted to have a different experience in how we approach public health, since it's one thing to learn about public health in the classroom, but really another to try to go out into communities and tackle real problems as a group. So this year, we participated in the DC Regional Public Health Case Challenge, which is put on by the National Academy of Medicine. So each year, they put forward a case that is centered on a public health issue that's currently affecting the DC area. And then each of about 7 schools that are in the DC area are invited to put forward a team of up to 6 students who are from interdisciplinary programs and field a case to solve this problem. So this year, the case challenge focused on urban change and the impact of chronic disease in vulnerable populations in DC. And we were given 2 weeks after receiving this case to put forward our program that we would present to judges. And this year we were given a budget of $2 million. And initially, we had to do a lot of research on our own because as medical students and an infectious disease graduate student, we didn't really know all that much about urban renewal, gentrification, or how that might impact chronic disease. And through doing our research, we really first came across the vulnerable population we wanted to target, and that was homeless children. And personally, I was really for targeting this population because of one statistic I read, and that was that at one elementary school within Washington, D.C., Ketchum Elementary, about 24% of the students there are homeless, which I thought was amazing to me that you would have a school with that high homelessness. So we had an idea of the vulnerable population we want to target, and we knew that chronic disease can be related to urban renewal, but we had a bit of a hard time getting a firm link to that. So initially, we had ideas of programs targeting obesity and mental health that we could target for our case.
Is this on? Okay. So we were really encouraged by our faculty advisor to actually go out into the community and talk to the people who we're trying to help. And that was something that we weren't really thinking of. We did only have 2 weeks to do this, so we were on a bit of a tight schedule. But we did make the effort to go out to 2 advisory neighborhood commission meetings in the wards 7 and 8. And when we got out there and we were able to talk to the community members and the people who we were hoping to assist with this proposed solution, we found that mental health seemed to be something that was on people's mind. And one story that really stood out to us in particular was of a young man who had faced homelessness as a high school student. And he really struggled with not having a solid shelter to live in, being very transient in where he was from day to day. And he suffered very greatly from depression. He ended up actually attempting suicide 4 times in his adolescence. But miraculously, he was able to develop a resiliency that led him to get an education and become now an employee of the DC government, where he works as an administrator. So we found that mental health was something that mattered to the community and was something that we found the numbers to support there being an issue of. Within homeless youth themselves, there's a high rate of mental illness and behavioral issues. Without stable homes, homeless youth can end up with rates of nearly 47% of either anxiety or depression, and behavior rates of 36% for delinquent or aggressive behaviors, compared to much lower rates in general population children. So the program that we decided to implement as best we could with the proposed money was to target stress where we could. With a proposed grant of $2 million, there's no way we would be able to effectively work on the driving issue of urban renewal. There's no way to change housing development issues, to make rent more equitable, to make housing prices more equitable, prices of goods and the services in the community more equitable. We could target what we could, and that was stress in the community. We saw that by developing coping skills and resiliency skills, we might be able to affect depression and mental illness rates amongst homeless children. So that's where our program came in, was to implement a program where we had psychologists and social workers that could work with these kids and help them develop skills that would cope with the stresses of daily life living as homeless youth. And now I want to talk a little bit more about what we came to understand out of this program and out of our research and our work. As 4 of us were medical students, we were looking at this as healthcare providers. And we really came to understand that illness is something that goes beyond the clinic. Just yesterday at my family medicine rotation, I met a patient that goes on dialysis 3 days a week, and he has issues with his sleep. So I was thinking, what can I give him to help him with his sleep? What would be the appropriate medication to help him sleep at night? Well, in talking to him, I realized that he was sleeping through his dialysis treatments because he was very anxious about them. He would be there for 4 hours a day with a machine pumping his blood in and out, and that drove him to be so anxious that the clinic had to put him on sedating medicine to keep him asleep. So for 8 hours of the daytime, he was asleep. And now, when he goes home at night, he's not able to maintain a proper sleep cycle. So we realized that things like illness are more than what we can just treat by looking at numbers and labs. And that's part of what we translated to the community identified needs and empiric assessment. We look at these areas and we find that there's high rates of obesity in poor areas, high rates of mental illness, a number of things, but we need to see what matters to the community. When we look at a community that's affected by gentrification and urban renewal, we see a lack of adequate housing. A lot of people live in old houses that have lead poisoning from the paint in the walls, things like that. And we say, how can we improve your housing? Well, what matters to the community is, how can I afford my housing? You tear down the housing developments that are already existing and put up something new and nice that I can live in, I can't afford that. So our metrics as academics don't necessarily line up with what the community needs and what they see as important to them. And also translating that to our roles as healthcare providers is shared decision making. That's something that's very important as providers to talk about with patients and help them understand what treatments we're trying to get them to go on, things that we're trying to help them with, and how that's going to help them in the long run. One example that comes to mind is statin use, Lipitor, Crestor, things that lower the bad cholesterol, so to speak. Your average patient doesn't necessarily think 50 years down the road, 30 years down the road, that my cholesterol is going to take, being low is going to help my heart disease. They may get the side effect of muscle ache, common side effect of statin use, Lipitor, and think, well, today this hurts my muscles. Why should I take it? Through shared decision-making and working with the patients and communities that we hope to affect, we can help them understand what we have found and how we can address those problems. and how best to address those problems. Because what works for us is not necessarily what works for our patients and our communities. Thank you. One last note, I would just like to give a special thanks to all the people that help support our case challenge. The Advisory Neighborhood Commission of Ward 7C and 8C, Shannon Adams of the Homeless Children and Youth Program Specialist of DC Public Schools, Marlon Dean, the Executive Director of Schools for Chavez Schools, our advisor, Dr. Diana Luan, and our team members who couldn't be here, Alex Leeds, Horace Hayes, and Evan Gregg, as well as Sarah Wright and Patty Vu. Thank you.
I think it was, no, please.